Hello. All presentations were quite nice, and mine will cover all of them. We still have ongoing debates on sluggish cognitive tempo and the possible treatment options that I will be speaking about. I will try to do it very briefly.
Yavaş bilgisayar tempodan bahsettikten sonra yeni bir tanımı, bir eş tanımı ya da bir alt tip mi?
So let's talk about presentation plan, what's sluggish cognitive tempo, and the treatment options that I will be talking about. As my friend said, the symptoms of SET have been recognized for nearly 30 years, especially in the past decade. Regarding symptoms of SET, we have ongoing researches, especially regardless of ADHD patients. The studies were planned. We don't have most improvements, but we tried to separate SET as a distinct condition than ADHD. As much as in half of the cases, SET is coexistent with ADHD, the evidence shows us that ACT in ADHD, we see that SET has its own symptoms and has very different symptoms in terms of comorbidity than ADHD. Also, demographic correlates in terms of lots of different features. SET is different, and it has a very distinctive structure. SET, especially two or more dimensions of SET are highly correlated with each other than ADHD. In ADHD dominant type, we have bicorrelation, but it also, this is a low correlation. In anxiety and depression, and in ADHD, we have some similar symptoms, but SET has very obvious symptoms. McConney et al. Made a study in 2009. In the school, there was an observational study for children regarding the distinctiveness of SET symptoms from those from ADHD. Again, for patients with ADHD dominant, SET has distinctive symptoms. In summary, Barkley et al. Did lots of studies and which made a consensus about the distinctness of SET from ADHD. Anxiety, in hypersomnia, and in depression can also be identified in SET. And also, we need to focus more on researches on distinctive features of SET than other diseases. And because we have low energy with depression, sleepiness with hypersomnia, so we need to focus on the specific features of SET. So at least two dimensions that seem unique to SET are daydream and sleepiness, sluggishness, and activeness. Those are the classifications. And in ADHD dominant type, persistence and low initiative is important, but they don't have much value for differential diagnosis. Also, semi-independence of SCT from ADHD is very important because of the population apart from ADHD. So SCT should be considered as a different diagnosis than ADHD. And in ADHD dominant type and SCT there is a correlation, but even though there's high rates of correlation in terms of impulsivity and hyperactivity, there is no correlation between SCT and ADHD. Again, both subtypes have high correlation, but hyperactivity and impulsivity, there is no correlation. Therefore, SCT, it shows us that SCT is different disease than ADHD, so that we cannot consider it as subtype. As for demographic features, since we have different demographic features, especially we don't have any variables with age. I mean, ADHD is a variable disease, but it is not the same for SCT. Gender, age, sex, and age is important. And also SCT has a later onset than ADHD. In contrast to ADHD, there's a greater association of SCT with lower parent education, lower income. And because of a disability, there might be this unemployment of the parents. Also, if there's comorbidity along with ADHD, and if there's a handicap or disability, then it has a higher rate than ADHD. We see ADHD, but how does it relate to anxiety disorder in terms of the differences? ADHD and anxiety are quite emphasized. I mean, do one induce the other, or in social functional disorders it was also concerned. In terms of among the most robust findings concerning impairment, researchers show us that SCT is associated with different distinct types of social disorders. What kind of findings? There's, aggressions, emotional and disruptive behavior disorders may lead to exclusion and being an outcast of the patient in ADHD, but it is not the same in SCT. SCT stems from withdrawal or social isolation. Even when you check IQ, there's a linkage between SCT and social withdrawal. And there might be behavioral disorder, depressive disorder, anxiety disorder. So SCT has its own distinctive symptoms. On the other hand, social problems, especially peer neglect, in the cases where SCT and ADHD can be seen as co-diagnosis, they are independent but not redundant, as researchers show us. When we consider the effects. In terms of demographical features, the social dysfunction stem from SCT. So that is how SCT differs from ADHD. What causes this? Because there might be coexistent symptoms like anxiety, depression, and social problems when it comes to SCT. And what are the causal pathways or relationship between this social isolation? So we need to investigate those topics. We can say that, continually seeing daydreams or having social difficulties. Due to these causes, peer neglect, or there might be problems regarding family, so it may lead to further anxiety and depression. Yes, it is possible. And in SCT, mind is always emphatic, so that may lead to problem. Mind is always tired, so it cannot divide its attention. So there might be greater symptoms of anxiety or depression that leads to either social withdrawal or SCT. But we should also consider that in all studies it was shown, especially in Buckley's study, SCT cases, according to normal controls, it is more related to anxiety and depression, but still it is a very small rate for the patients with SCT. So the onset of SCT and also coexistent depression and anxiety disorder, it cannot be directly correlated.
Another study actually indicates that it was conducted in 2001 by Leahy, and actually it analyzed whether SCT simply represents the attention problem associated with, and actually it showed that it's different from ACT findings. Well, after all, we have some lethargy, low energy, and sleepiness, and should we evaluate all of the symptoms as depression, or is it a PTSD? So with the same reason, before the ACT, when these children were evaluated, in the depression diagnosed one's ratio was pretty low. So in the ACT, we have a different indicator clusters, and I think it's possible to talk about this different indicators. And actually, we cannot be talking about coexistent diagnosis. And we have lots of studies on that regard. And actually, they showed that the indicators are not related to depression or anxiety. We cannot say that they are the precursors of each other. Well, in summary, individual studies and meta-analysis of SCT, symptoms of SCT, show that they are coherent among themselves. They are highly correlated with each other, and it's a separate disorder. And with the depression, anxiety, although there is a common symptoms, but there are no overlapping symptoms. They have different symptom clusters, and they actually have a significant stability over long periods. And in time, actually, this is a 10-year-long study. Even in 9 years, the presence of symptoms actually are stable. And when compared with in other disorders, it should be evaluated as a different entity. And actually, between parent and child ratings, actually there are some low to moderate relationships. And actually there is a cross-cultural transmission or presence maybe in question. Well, in American, Afro-American and Hispanic cultures were included in the study, but we have studies in Turkey too, so I think it's significant. So what about treatment of SCT? Well, in just only SCT groups, there are no precise treatment. In ADHD groups, they specialized the SCT symptoms and they evaluated the symptoms, and it indicated that while methylphenidate actually treated the ADHD, it couldn't have an effect on SCT, but Barkley had a study on that group, but he still had a mild positive response to treatment in terms of methylphenidate, but in terms of adverse events, just only 20% of individuals could get a positive response. And there is a recent research and it showed that in higher SCT groups, whether it's a pure SCT or not, actually it's consistent with the earlier studies on ADDH or the predominantly inattentive type of ADHD, so we can say that it's compliant with previous studies. There is only one study in ADHD diagnosed group for treating SCT symptoms. This was done in atomoxetine, and actually it showed that the reduction in SCT symptoms remained evident. So atomoxetine was actually effective, and actually it's very important because actually it's improved the SCT symptoms. So what other medications can be an option for SCT? As far as I know, Elif is very actually focusing on that. In the anxiety and depression, some SCT symptoms are overlapping. So why SSRIs couldn't be an option? Actually, because we need some activating antidepressants, it might be another option, because it might actually lead to a reduction in the drowsiness and sleepiness, but we don't have enough evidence on that. Another point of view is that in terms of fluvoxamine, it's an SSRI, but in OCB, actually it's effective. So if we have obsessional thoughts but not diagnosed one, maybe this treatment option can be thought, but we cannot say it for each SCT case. Another recommendation is about anti-narcoleptics, because we have hypersomnia or daytime sleepiness, and actually sluggishness is pretty related to that. Maybe modafinil might be an option as an anti-narcoleptics, because we know that modafinil is used in adult patients too. Another option is that actually we use it more in ADHD. Alpha-2 agonist guanfacine XR might be an option. Well, these are the options, but we need further studies on these drugs. And maybe behavior modification methods might be an option. Actually, there are 2 studies conducted on that issue. But actually, the studies were done in the predominantly inattentive ADHD diagnosed people, and many of them had SCT. And especially in the traditional behavioral management, correction was on the forefront on that studies, and the specific symptoms of SCT, actually they get good results and good response. Another thing is that in the ADHD and SCT combined cases, in the children with ADHD inattention type improved more in terms of their assertion skills than those with ADHD combined type. Maybe not an alternative, but maybe it might be a complementary treatment option. Another option is the cognitive behavioral therapy. Although it's used or it has a proven effect, well, I think it has not been shown to be useful for ADHD. And maybe if the ADHD is coexistent, we know that for cases of anxiety or depression, it might be an option, but we don't have exact and precise results. But in terms of SCT, if it might be worth exploring as a possible intervention, given the higher than expected people might be using it. Thank you for your attention.